but I appreciate this. Hopefully you guys can see this is the intro slide for VELYS Hip Navigation talk. And I'm going to try to talk about just how the power of fluoroscopy can be enhanced with technology. And with a direct anterior approach, primarily, this is the kind of technology that can really give you data when you're trying to look at an x-ray in a setting that you may not be comfortable with. These are my disclosures, certainly as a consultant for DePuy, and then as one of the developers of JointPoint. That certainly will conflict me as well. I want to demo an actual case, and I have about 10 minutes, which for me is quite challenging because I tend to like to talk, but I certainly want to kind of show the technology on a real case and just get a perspective of how this can work in the operating room for people that use anterior approach hips. Certainly, when you look at templating, for instance, there's a lot of opportunity to template a case. And sorry, I didn't start my video. You can see my shiny head now, which I'm sure enhances the talk. Templating, obviously, I like to go over and start with that because certainly templating is a nice kind of preamble to how it gives you a plan, but certainly it doesn't necessarily tell you exactly how you're going to execute the plan in the OR. As everybody I'm sure is aware, when you template, this is the plan on where you put your cup and where you plan to put your stem. And if you put your cup precisely there and your stem precisely there and that alignment, your image is scaled correctly, you can achieve a leg length and offset change with this cup and stem construct. Of course, in the operating room, whether you're using fluoroscopy or not, you may put your cup a little higher and your stem could go a little lower and could be in a little bit of varus. And if you knew you're going to put your cup precisely there and your stem precisely there in that alignment, and you had an analytic in the OR to tell you that you did, maybe with data, you would choose a very different construct, such as a standard offset +5. So the transition to a plan to what you do in the OR can sometimes be subtle, can sometimes be significant. And those deviations from your plan and execution is where outliers can happen. And obviously, at the end of the day, we all want to get it right. And with fluoroscopy, we should be able to do that. We all know what kind of x-ray we're trying to get in the office and what kind of patient satisfaction we want. And having x-ray in the OR can allow you to achieve that if you can understand the subtle perceptions that can happen with fluoroscopy, and technology can help you do that. So fast forward to the same sort of case in the operating room, and I can kind of go over what actually happened versus what I planned. And everybody has a different kind of, but the goal of this, of course, is to try to use x-ray to your advantage, and as opposed to being a hindrance, as opposed to being something that takes a lot of time in the OR, something that can challenge your workflow. And when I started doing hips in 2011, kind of self-taught, did not have any education of it in fellowship in 08. I got really good at the approach, but had a lot of problems with some of what I call the inefficiencies of anterior hips. And people that do a lot of them understand what that is, use of fluoroscopy, trialing, retrialing, re-x-ray, redrawing lines. And that was where we were at in 2011. And, this technology will instead get you to the point where you take an x-ray, you work, take another x-ray, you get data, and then you can make a decision what's best for the patient. So my workflow is I take the x-ray on the left here, either before I make my neck cut or while I'm at the scrub sink. Once this x-ray on the left is taken, which is the hip before I operate, I'm off and running as a surgeon. I'm making my neck cut. I'm about to get my acetabular exposure, and in the back side of the case, usually a representative or a nurse can mark these points. I don't know they're happening because I'm in the OR and I'm operating. And then I put my cup in, and when I put my cup in, I can show you that in a second. But as you can imagine, once I put my acetabular component in, I'm going to analyze that x-ray and get an analytic on what my cup position is in. And then at that point, I'm going to broach the femur and get my trial x-ray. And as you can probably imagine from this trial, I have all the relevant data to give me a perfect template. I kind of know exactly where I put my cup. I know the size of that cup. I know exactly the size of the stem I put in and the height and the alignment. And I have my initial x-ray. So because of all the data on this right side of the screen here, I have all the data to put a perfect template in the system. And as you guys know, with a perfect template, you are then able to make what's best decision for the patient in terms of offset and leg length. And so my workflow is I literally take the x-ray on the right, I'm operating, I have more registration going on the back end of the room, and then I get a data chart. And before I look at the data chart, As probably people know from overlays, we are counteracting for a lot of the inefficiencies of X-ray that we try to do with our eyes, rotating, translating, transposing images, correcting for abduction, adduction differences of the femur, all the things that we like to do to get the images to match and to get proper data. The technology does seamlessly with some of the registration points. And then furthermore, quantifies things into a chart. And when you look at this chart, it's giving you a lot of data. And when you look at the Karai stem, for instance, and this works with the whatever stem you're using, this stem tends to have tons of modular options, as a lot of systems do. And you can pretty much go anywhere you want with modularity. But the difference is it's going to tell you what that is going to get you to without having to trial. And as anybody that knows with anterior approach surgery, especially if you're using a table, that's not such a quick adventure. You're dislocating the hip, you're re-putting a new construct in, you're reducing it, bringing in an X-ray, you're analyzing it. And to be able to have to do that only once and to get a full set of data is really helpful, because I can trial and I can get a data chart. And what this data chart is telling me is where I'm at now, which is the highlighted box, which means I'm short 4, -4, and I'm over offset by 6. It also tells me if I go to a +5 with this stem type, I'm going to be -2 of length and over offset by 9. And then with a +9, I'm 0 and 12. So I could get back to my leg length with this construct here, but I think we'd all know that we'd have a lot of trope bursitis for that patient, and there may be a better option. So with modularity, I can choose this option. So this option is a 135 neck angle, standard offset +5. So, the power of technology is, of course, is that, who could literally, with this image on the right, take that X-ray trial, plan with your template to put in this construct, and then look at the X-ray on the fly and ask your rep to open up a totally different option to get the best net offset option for leg length for that patient. And, that's what technology does. Whether I get it right on my first trial or not, I know I'm going to take an X-ray, I'm going to get a chart, and then I can make the best decision for the patient based on the modularity of the stem between the neck sizes and the head sizes. So it becomes very powerful because, obviously at the end of the day, I don't think my patient necessarily cares how I get to a proper leg length and offset position. I can tell you right now, I did not put my cup where I planned. It's definitely more superior than my template. That's where I lost some leg length and offset. And at the end of the day, it doesn't necessarily matter how I got to this chart, but this is the net result of where I put my cup, where I put my stem. And it's telling me, okay, Cooper, you didn't hit your template right because you're not where you want to be. But fortunately, with modularity, there's an option on this chart that you're happy with. So the power of technology is the workflow is the same. You take an X-ray and you get data. And at the end of the day, whether you're a new surgeon, intermediate surgeon, or experienced surgeon, I do feel strongly that we're all better with data. Of course, as you get more experience, you get the X factor, you have a better understanding of what is acceptable, you have better gestalt, and your outlier reduction becomes much, much less. And, at the end of the day, if there's a technology that, I always joke, if you use fluoro, most people want to use less. And this technology actually can make you more efficient with technology. And, with technologies, you don't want it to hinder what you're normally doing. You don't want to have to add a lot of pins. You don't want to have to add a lot of additional steps. And if you do, you're weighing that additional time and energy and cost with the benefit of the data. And in this situation, the benefit of the data, which is pretty extensive, really can actually help you with time savings because you're not having to retrial, you're not having to reanalyze things. So once this is in your workflow, it becomes quite seamless. You take an X-ray, you operate. You take an X-ray, you operate. You take a last X-ray, you get a chart, and you decide, and then you're done. And before I get to the other missing piece, which of course is the cup side, I think this is kind of the way that most surgeons will find real efficiency with data, because they can trial with whatever they want and they can get to whatever option they want based on their plan. And on the cup side, it's a little bit easier in some ways to understand, but it's also a little bit harder. And I say that because the one trial leg length and offset data is very simple and easy to reproduce, because you're just matching two images that don't necessarily have to be, they have to be similar images, but they don't have to be a proper image. With the cup, as everybody I'm sure knows, if you have an iliac oblique or an obturator oblique, and then God forbid we talk about tilt, the value of this analytic is totally based on your ability as a surgeon to get a level pelvis. So if you have a level pelvis, you won't have a surprise, and this will position your cup the way that you think. If you don't have a level pelvis, if it's too iliac oblique or obturator oblique, this will look differently in the OR than it will in your office. So we do request and require the surgeon to get a level pelvis first. Down the road, we're going to have technology that can, of course, help you with the tilt. And that's a whole nother discussion. Do you want your tilt to match your standing x-ray, your supine x-ray? It's ironic that we put our cup in our either lateral decubitus or supine. And, I can tell you supine position is not really where my patients are going to dislocate. They're probably going to dislocate when they sit or stand. So we analyze a cup in our supine position. We pat ourselves on the back and say it's a great cup. And it may be, but there's a missing piece here. Like, what is our cup going to look like in these extremes? And that is, I think, there's a lot of technology already out there that addresses tilt. And I think that is the next phase of this technology where we can really help you with, all right, here's what your cup looks like right now, but let's make sure that you're happy with what it's going to look like in all settings. So I have a chat thing. I'm almost certain they're telling me to wrap it up, which I am. But at the end of the day, I'm hopeful that I can impress upon you when you trial something like this. Once it's again your workflow, the goal, of course, is to not slow you down. It's actually to make fluoroscopy be used to your benefit, to reduce the headache. I use 6 to 8 seconds of fluoro now. I do cases in 25 to 30 minutes. I promise you, I'm not a technically gifted surgeon at any means. I have an ability now to have a great workflow with, the technologies that I use, that I don't waste time with x-ray anymore. I use it to my advantage, and I greatly feel that technology can make that a reality.